very much. It's a great pleasure to be here, and I think this is the first time I've presented where I've started before my presentation time. So those of you who are still coming in, you're still early, you're not late. So thank you very much, Donna, and all of the other organizers for this wonderful opportunity. It's a privilege to be here with you. I'm just going to jump right into my first slide that has objectives, which I think you already have, and it has one disclosure on it as well. And I want to go right to the next slide to actually flesh out the objectives that I have. In a sense, I'm trying to already get to the end of the talk by giving you a sense of where I'm starting and where I'm going. And I happen to be a general internal medicine physician, so I'm not one of many of you, but at the same time, we all are in the same kinds of situations fundamentally, I believe. There's this thing that we refer to as shared, can you all hear me okay? Is that coming through? Good, okay. What we call shared clinical decision making. When I use that phrase and talk about it, sometimes I'll ask physicians, do you think that shared clinical decision making really happens? Right? Is that decision making really shared, or is it just a nice phrase that we use to give the impression that we're being generous as clinicians with our patients and their families, etc.? And I like to believe that I think it really does happen. When those of us are at our better moments, we're actually genuinely sharing, we're having a dialogue with our patients in a way that really allows us to respect them, and they to listen to us, and each of us to respect each other's skills, shall we say, and the values and beliefs that we bring into this process. But the point I want to make here is, of course, there are these beliefs and values that are playing into what we are saying and what we are doing with our patients. And sometimes I think it's very disappointing when one gets the impression that medicine is some kind of a value-neutral technical enterprise, as if there were no beliefs or values that are interpreting and assessing and advising and leading and guiding all the time. And what I think plays into that misconception is that when you can see here when we talk about treatments, so often medicine focuses on what are we going to do or not to do, as opposed to what's the purpose for that doing, and then even stepping back further, what's even behind that. So what I'm trying to get at today, as lofty as it may at first seem, is to step back not only one step, but maybe two steps, and ask what is the framework of belief and value that really guides what we're doing. I realize that as I'm saying this, a lot of you will probably be thinking, I think I already understand what he means by this, because there's nothing very new or novel about this, but at the same time, I think that so much is taken for granted, and we've been so socialized in medicine to buy into certain frameworks that sometimes we're not aware or as easily able to see where some very fundamental differences may be. And what I'm going to try to suggest to you all is that we should have a range of concern when it comes to concepts of health that is very broad. And I'm going to clarify that later on, but we need to have a scope of practice that is actually very focused in terms of having, so we want to be aware of the big picture, but we want to be modest about what our expertise is. And then, of course, this what some would call the locus of control. We want to say that that's genuinely shared between us and our patients. So we'll come to those kinds of issues. And sort of overarching over all this is this question of human flourishing. I don't know if that's a phrase that you all use in your thinking and your speaking in any contexts, but it's really trying to ask, what is a life worth living? What are we meant to be as human beings? What is a good life? What is a healthy life? How do these things fit together? And to what extent does that directly or indirectly influence what we're actually doing with our patients and for them? So you can see some of those sort of overlapping sort of those circles there that get at what I've already been talking about. And I'm going to give you quickly, to jump into clinical reality, some examples from my own work as an internist, or also I work as a clinician ethicist in our hospital. So imagine a 78-year-old woman in hospital with poor memory and chronic weakness who is unsafe at home and does not want to go to an extended care facility. This is not an uncommon cause for an ethics consultation in our hospital. And you might ask yourself rightly, what does this have to do with health, where a human being lives? Now, in one sense, you're thinking, well, of course it has to do with health. This is, if a patient is falling and knocking their head and getting subdural hematomas, that has to do with health. But at the same time, we can quickly see how we can medicalize this notion of, man, what you need most is to be safe. as opposed to someone who says, no, I'd rather be living my life in a certain sort of way, even if you medical types think that that is unsafe for me in some respect. We're just trying to quickly open up some very common sort of scenarios to ask ourselves, what is the medical expertise about where someone lives and what risks they're willing to take or not take in life? Or how about a 40-year-old man with chronic osteomyelitis of the foot who does not want an amputation? And I know from my own experience in the situation that I had in mind here, this was extremely frustrating, not only for the primary general medicine team, but for the infectious disease service, and also for the nephrology folks in hemodialysis, who had to work with a man who would come to the outpatient dialysis clinic with his wound literally dripping onto the floor. They didn't quite appreciate that. And everyone was wondering, why won't this man realize that what he needs is an amputation? But he was insistent that he would not have an amputation. So what is it about us saying to this man, my friend, you have the wrong concept of health? You should listen to us. We can help you understand what's in your best interest, what's healthy for you. Now, these are two examples of people who are saying no or no thank you to what we're saying that they should be mindful of. How about the other direction? So what about a 52-year-old man with chronic non-malignant low back pain who wants a prescription for opioid analgesics for pain relief? But I, as his internist, say, I do not believe this is actually the best thing for your health, at least in the long term. Even though you say, doctor, you can't feel my pain, how can you tell me what is best for my health? Okay? So now the directionality flips, where the patient's asking something of me and I'm saying that I can't do that because I don't think it's good for that man. Or how about what happened to me only once so far, a 38-year-old woman with a demanding work schedule who wants a prescription for modafinil so she can work more and sleep less. So once again, she has a vision of her life in terms of what health looks like. And I'm asking myself, but is that the notion of health that I have in my mind? You all can think of many examples in both directions from your own clinical practice. And what I'm trying to get at here is that there are concepts of health that we're working with, implicitly or explicitly, that I think are driving what we're thinking, what we're saying, and I would wonder whether at a certain point, is it appropriate, and I believe it would be under the right circumstances, to actually be able to articulate some of these differences with our patients as a respectful way of communicating with them, of actually being honest with them, and saying, let me explain to you why I need to say no to what you're saying, or let me explain to you why I'm trying to persuade you to something. We'll come to persuasion in a little bit. So, concepts of health. There's a very nice paper that you might want to read by some authors who published a few years back to try to get at the question, how do patients think about health? And so they asked the question, are you healthy? And the patient would say yes or no. And then if the patient said, well, regardless of the patient, they'd say, how do you know that you're healthy? And it was very interesting to see that based on some elaborate work that they had done, they developed a taxonomy where they had 4 different basic concepts of health that came out of this empirical work. And I think this will immediately resonate with us as clinicians as we see this. But I think it's important for us to realize that our patients have their own concepts of health that they're working with. In any given situation, it may to some degree explain why we might sometimes not be seeing eye to eye. Now, the physical definition, of course, or concept is the one that most of us have been very well schooled in. And then, of course, psychosocial, we can understand that. And the capacity notion, we're going to come to that later on in the talk, this idea of being enabled to live the life that you believe you want or need to live. Then there's that last one that's about control. Some people think of health as being able to be controlling the circumstances of their health, and that somehow speaks to them. They put together a nice Venn diagram that gives a sense of how these different concepts are overlapping, and I think the physical still predominates. But I think it's important for us as we're working with our patients, especially, let's say, for I as an internal medicine doctor, I not uncommonly have to work very hard with my patients to see if they can find the motivation to do certain things. And sometimes, this so-called motivational interviewing is to try to find something in the patient that is valuable enough for them to drive their decision to change their behaviors, etc. And I think even the idea of concept of health is important. In fact, as I was once preparing a related talk on concepts of health, I was in clinic on a Tuesday morning, and so I decided I'd try out this question that these authors of the study used. And so I asked my patient, I said, would you say that you're healthy? And the patient's answer to me, I won't forget, was, she said, Doc, I may not look very good on paper, but I feel good. And I think that's a nice example, isn't it? About how we see our numbers, we see the things that make us think someone is or isn't healthy, and yet they may have a different view, and that may explain why they don't seem to be too enthusiastic about following certain of our recommendations. So, concepts of health. Historically, on the one hand, let me just take one step back for a moment. Some of you also might be thinking, wow, here we are at a medical meeting talking about concepts of health. I thought they call us healthcare providers. I thought we see billboards that say, things about health. We have health centers. If there are questions about what health means, how could all these other things be happening? I understand that. Thankfully, there's a lot of consensus about health in ways that we would understand and support. But on the other hand, if you actually especially look at the margins of how health is described and how it changes over time, it's a fascinating history. So I encourage you to look at some of these and other references if you're interested to see what has happened over time. Philosophically, there's certainly our contrast between those who would think of health as being very much an objective reality versus those who would say it's a subjective one or a mixture of the two. And we're going to be coming back to that later in the talk. I'm somewhat fascinated by those who would take a sociological perspective and say, give a definition like Talcott Parsons did when he said that health is the state of optimum capacity of an individual for the effective performance of the roles and tasks for which he has been socialized. That certainly wasn't the definition of health I grew up with in medical school. But you can see how differently different people can look at what health is. All right? So, this first point here is just to recapitulate the idea that we want to try to step back from just looking at treatments, what someone does or doesn't want to do in terms of a treatment, to step back to goals of care and to step back then from there to concepts of health, on the presumption that one thing actually leads to another. And the second point here about practical wisdom, it's an area that is of great interest to me, and it really is about means and ends in a very good sense, in the sense that human action should be intentional, it should be end-oriented. You should be doing something for a purpose, with a goal. And so practical wisdom in all of life is about trying to find the most appropriate means to that worthwhile end. Thankfully, I think the whole goals of care language, which I trust is very familiar to everyone in this room. In fact, I don't know about you, but in our hospital, for instance, we have a palliative care service, and I'm sure you work in places that they do as well. And sometimes it's my impression that the palliative care service is known as the goals of care service. You should ask yourself what that is getting at, okay? And it's, to me, what it's getting at is because people are having usually some kind of a disagreement or a difference of view, and now they're being forced to take that step back and say, wait a minute, what's the point here? Which direction are we supposed to be going? What's the goal? And so often, sadly, it's because some services would rather not have to have and do the work of those conversations, and so they ask our palliative care colleagues to do that. My presumption would be is that all of us should be members of a goals of care service, because that should be part of all of the medicine that we do. It should be goal-oriented. We'll come more to that in a moment. So I think that talking about goals of care does give us windows into concepts of health, and I think it also reminds us that what we think of in terms of medical goals of care may be in contrast to what patients have as their own goals. And this is just a schema of an approach to clinical ethical reasoning that we use in my institution, at least I do as an educator. And part of it explicitly contrasts medical goals from patients' goals and preferences. Now, thankfully, at least from my own vantage point as a clinician, most of the time, there's a nice overlap between what I'm thinking about medical goals and what my patients are thinking about goals. Such that if I'm caring for a 45-year-old with pneumonia, I usually don't have to have a conversation about, sir, I just want to be sure that your goal is the same as mine, that you are really interested in having this pneumonia go away through the use of antibiotics, et cetera, et cetera. Or a young person with a fracture of the ear. they find it somewhat strange and maybe even obnoxious to have that goal discussion. But all I have to do is change the circumstance, right? So think about, instead of that 18-year-old with a fracture in the ER, an 88-year-old with a fracture, who now has to choose between the risks of dying in the OR from to repair the fracture versus the risks of getting a DVT from being bedridden in a nursing home. All of a sudden, the questions about goals really come up in terms of what's most important to you now at this point in your life. So that's why we encourage, in our own institution, to what degree of success I'm not sure we're having, but we encourage us, whenever we're having treatment-oriented discussions, to place them in a context of goals of care, especially in the so-called DNR order discussions, which often tend to be very isolated. They drop out of nowhere as something unto themselves, sort of, "Ma'am, sir, if you were dying, would you want us to resuscitate you?" All these discussions happen in so many different ways. But we encourage folks to first have the goals of care discussion and then move in that direction. So you might be asking, well, what goals of care are you talking about? These were derived from a structured literature view in the context of end-of-life decision-making, end-of-life care. But I would want to suggest that these goals are relevant across the board, not just at the end of life. And so you can see the first four are very intuitive. They range from cure to comfort, right? And then the achieve life goals, certainly relevant towards the end of life, but not only so. And then what's that number 6, you might be wondering, what does that mean? That's a very, very special moment, I think, when a patient, an adult patient, let's say, says, "Doctor, you know what's most important to me is actually what's best for my loved ones." So whichever of these options we're talking about, it's really more about them right now than it is about me. And then, of course, especially in hospital-based medicine, the most important thing often is just to clarify what's going on so that you can then have a rational conversation about what most important goals may be there. So to me, it's interesting how often people will say, well, the patient needs to have a goals of care discussion. And if I ask someone, especially a trainee, okay, so tell me, what are the goals of care you're talking about? Can you actually list them? What do you have in mind? Or is it more just a gestalt of we just need to figure out what we're supposed to be doing? I encourage folks to actually have this kind of a list, or one that they think is better, where you can actually say with a patient, begin with an open-ended question. "Ma'am or sir, can you tell me what your most important goals of care are?" And we actually did this in a study context. Most patients will actually answer that question as phrased. But if they don't, you can follow it up with, "Well, could you tell me what you're expecting from your care or from your hospitalization?" And depending on what you get, you can then follow it up with the closed-ended options. And I will sometimes say, if I'm having code status discussions, say with outpatient advanced directive type discussions with patients, I will literally walk through this list and say to them, many patients in your situation tend to have these kinds of goals. And when I get to the ones that are most important to that person, they tend to start nodding their head. And it becomes a nice way. So the open-ended, closed-ended is a very good form of that kind of dialogue. So the next slide is to emphasize a point and you'll see with the next click here, this bit of animation, the point being that really, if you think about it, we would do better to first, once we know what's going on, what the it is, what the diagnosis, prognosis is, to then try to get clear on what goals are important or most important. Then say, "Now, ma'am or sir, based on what we've talked about, what you've explained to me, when we're thinking about different possible interventions, does it make sense, whether it's resuscitation, whether it's a surgery, whether it's a medication, does it make sense now that we would think that this intervention would help you achieve the goal we just talked about?" Okay. Now, having said that, goals are not self-justifying. So one of the reasons why a palliative care service might be called in the hospital is that a patient might have a goal that the doctors don't share. One of the best examples, say, in adult medicine, also I'm sure in many cases in pediatrics, would be the so-called questions of medical futility. I know that's a loaded word, so I'm not going to deal with the loadedness of that word right now. But it's to say that there are patients or their family members who want to continue to try to keep a human being alive, and the doctors and nurses are wondering, why is this going on? Why doesn't the family realize that now it's time to let go and let this person die gracefully and comfortably, etc.? So we need to be able to put goals into the context of something larger, and that's why we're talking about today about concepts of health. And then also to keep in mind this, what I would like to use this language, it may not be as natural to some of you, but the idea of ultimate ends versus penultimate. So penultimate, just before the end. So not the last thing, but the second to last sort of thing. And so when we talk about human flourishing as being the final sort of description of what human life is worth, what it's supposed to be about, one of the nice things about being in healthcare is that we can talk about ends and goals without having to agree on the final end. So you see where I'm going with this. And as a Christian, for instance, I think about different Christian traditions, and they talk about what is the final purpose of life. And there are different ways. I mean, in the Catholic tradition, though I'm not myself Catholic, the beatific vision, this mystical union with Christ. I come from a Reformed tradition, that has something like the Heidelberg Catechism that talks about what is my one purpose and goal in life. And there are famous statements about what the purpose of life is. Now, caring for patients who are neither Catholic or Protestant or Christian at all, each person, of course, in our society, in a pluralistic context, will have their own sense, articulate or less articulate, of what their lives should be about. Why am I going on about this? That's to say that in one sense, I think it's good that our expertise doesn't have to deal with that. That's not our job description in healthcare, right? So we can step back from that and talk about the penultimate end of health. But having said that, I think the kinds of especially controversial questions that we're talking about at a meeting like this is to say that there's a merging and a blurring or a sliding from one to the other. And so when someone has a vision of their life and what's meaningful to them, it says, that's what health is to me. I think in a sense, you start to see this collapsing of health into this idea of what human flourishing is and what the purpose of life is. Okay, so but now I want to take another sort of sidestep over to shared decision making, to really remind ourselves of how dynamic the relationship between a clinician and a patient is, especially I think doctors and patients. So we talked about shared decision making, it's the column in the middle. To the opposite extremes, you can think about the informed model to the right. The idea, it's almost like going to the fast food restaurant and seeing the menu of options, and you'd be surprised if someone behind the counter ever suggested to you, my friend, I think you chose a 3, but I think a 2 would be better for you. And then you'd say, well, wait a minute, why are you telling me? That's not your job. So, and the other would be the paternalistic model where you walk up to the counter and there's no menu, somebody just tells you, this is what you're getting today, right? Okay, so and some of you may prefer maternalistic or parentalistic, whatever you want to say. And this question of paternalism is profoundly serious. Because one of the things I like to say about it, to remind ourselves, is when would we say that paternalism is good? Well, if you happen to be a father and you have a 5-year-old child, you can bet we would say paternalism is good. That's your job as a paternalist. Okay, but now when you're caring for a patient, especially an adult patient, that is not your job. Because what the good thing about paternalism is you're trying to do good for another human being. The bad thing about it in the wrong context is that you're telling another human being, I get to decide for you what good is for you. So paternalism at its best is very well intentioned. It's just mistaken at its worst, if you follow me. We'll come back to that towards the end. So shared decision making. A more sophisticated description of this is from a paper here from, dates didn't get on there, but it's 2012. And it's just to say, for those of you who may not be familiar with this literature, there's a very sophisticated sort of analysis of what shared decision making is believed to look like these days. And I would just suggest to you, though, that if you even a quick glance at these main categories of choice talk, option talk, and decision talk, it's profoundly patient autonomy based. And autonomy is understood as informed choice. That shouldn't surprise anyone in this room. But one of the things I would very much ask is, where's the doctor in all this? I think the doctor is really seen, or the nurse, or whoever's involved in this shared decision making, is really almost being presented implicitly as a facilitator, as someone whose own personal presence isn't necessarily part of the mix. And in fact, I think some would want to argue should not be part of the mix. But I would then say, is that is that really the way things are or are supposed to be? Because in what sense could you say that it's really shared? Now, someone would say, well, the sharing is that you're providing the information. But how about if you're also contributing to your sense, with your sense, of what you actually think is good for another human being? And on that, well, actually, I'm going to get back to that in another moment, but beforehand, I want to also make a quick side remark that's actually not really off to the side. It's right in a sentence to say that in addition to goals, there are other dimensions of decision making. And I would, so that's that animated moment there. And then here, the probability of outcomes is another dimension. I know you all know this. And then another would be what I tend to refer to as willingness to accept suffering or the level of treatment burden. I think this little schema, as simple as it is, I think explains most of what we do when we're doing our job well as clinicians in shared decision making. This is what we should be doing all the time. His impression and discussion at the end of his note that so nicely captured these domains, and you could see that he had really gone through in nice detail with the patient what is at stake in a difficult decision about whether to take chemotherapy or not. So we have to talk about goals, probabilities, and suffering. Another one that I put a bit sort of in a shady color is cost. Not because I don't acknowledge that it's a problem, that a profound issue at the one-on-one level and at the macro level. But, and I know this is a whole other discussion, another talk, my own position on this is that we shouldn't wear two hats at one time. Because if I'm going to be a cost controller and cost manager for a population, while I'm also delivering care to one individual at a time, I would suggest that I have more than a competing obligation. I would call that a conflict of interest of a sort. I know that some of you might disagree with that. I know it's a lively debate, but I just want to tag it to set it aside. Now, having said that, I brought up cost with one of my patients this last week in a conversation because I was treating bacterial overgrowth of his intestine. And there's a drug called rifaximin, and his out-of-pocket cost for that drug would have been $408. And I told him we could also try, though the data might suggest it's not quite as good, some good old metronidazole, which would cost you about $7 or $8. He took the $7 or $8, and we'll see what happens next. But the point being is there can be a very respectful way, especially if it's somebody really trusts you and doesn't think you're concerned about costs more than you're concerned about them. Okay, so getting back to goals of care here and these other dimensions. I would want to suggest that you could say that there are domains of expertise between the patient and the clinician, and somehow or other, in the best of sort of dialogues, these different influences are traveling back and forth in that relationship and determining an outcome of a decision. But of course, there's more to this as well. And what I think is very important to think about is think about all the times when you're talking to patients, when you're communicating, to what extent are you giving information? To what extent are you making a recommendation? And to what extent are you at times trying to persuade? What's going on when you move from informing to recommending to persuading? Now, I hope you would never cross the line and go to manipulation and coercion. But I suspect each of us has stories about having observed such things, and maybe if somebody videotaped me throughout my career, they might say, Kaldjian, your persuasion, I call that manipulation. Granted, there can be differences of view on what constitutes what. But I think this range from informing to recommending to persuading, it's telling us something about what we believe. It's telling us something about what we believe is good for another human being. And I would want to suggest that especially when we go so far as to respectfully try to persuade the patient, I suspect at times we have a different concept of health. And I think that's what was happening to this patient I told you about who had the infected foot. There were clearly people trying to persuade this man. And I think it's because people were coming from different concepts of health there. On the note of persuasion, there's a nice piece here by someone from the UK, Rainy Gillen, who's written a lot over the years in medical ethics. And I like the way he talks about persuasion because he grants, even though he's a big fan of the so-called 4 principles of respect for patient autonomy, he is a fan of persuasion, but he reminds us that the point about persuasion is not that we persuade patients, but that we sometimes try to persuade patients. I hope you can appreciate that difference, right? It's not the outcome. but it's that it's very legitimate, sometimes the responsible thing for us to do, to actually try to move them in what we believe is a better direction. That's not only a sign of respect, I would want to say that's a sign of love. It's actually wish the well-being of that person so deeply that you're willing to argue with them. Those of you who are parents and have had arguments with your children over the years, think about what love could look like at the most strenuous moments of attempted persuasion. Right? And then what it could look like if persuasion becomes something stronger than attempt, shall we say. And then maybe that has to do, pediatricians, I guess, know this very well, as the ages move from a certain age to then those later ages and what that looks like. Okay. So then the second point here is to say that this range from informing to recommending to persuading is so much about concepts of health, but also about this basic tension between autonomy and beneficence. Remember, so autonomy has to do with self-determination, letting patients decide for themselves what they believe is in their best interest and what is good for them. Beneficence is doing good, but in the tradition of beneficence that goes back, speaking about Hippocratic medicine, goes back to Hippocrates and that tradition. It's about our belief that we know what is good for another human being. And so it's that tension about what we think is best for them, what they think is best for themselves, is what creates the problem. So now returning to the concepts of health. How many of you happen to have been familiar with this WHO definition of health? Just some. And it's shall we say, a very broad, wide-ranging definition, right? And some of you, I can see by your faces, you're resonating with what Paul Ramsey then wrote about some years ago already, back in 1970, who said that definition presumes to locate medical considerations in direct lineage with all of man's moral reflection upon the meaning of eudaimonia since Aristotle. It would seem wise for the medical profession to hesitate before assuming the tasks of an entire moral philosophy under a definition of health as general human well-being. So there's a very powerful and important caution that Ramsey is giving us. And yet, some of us are also sitting here thinking, but wait a minute, isn't there something right and good about what he's getting at? And now, from a text by O'Rourke and his colleagues, they help us see what's good about this. And this notion of optimal human functioning and what human function really entails has these different dimensions of health, right? And I suspect all of you in this room are familiar with not just the biomedical or the biopsychosocial, but the so-called biopsychosocial spiritual notion of health. And this is what would cause me to say that one could maybe, if this is helpful, distinguish between an expansive concept of health versus an expansionist concept of health, right? Where you're actually starting to now take things on board that shouldn't be your own, that aren't part of your own skill set. But an awareness of this is important. So here's where I want to make this contrast between a range of concern and a scope of practice. So who do we think we are as clinicians when we are on the one hand aware of what health looks like in its fullness, but then are we mindful, but wait a minute, what is my job here as someone who's gone to medical school as opposed to human flourishing school, right? I mean, that's what I'm trying to get at. Even though we say, but wait a minute, you're asking me to be able to sort of bifurcate myself. I can't step outside of my own skin when I know what I think I know a good life looks like. Okay, but there's more to be said about that, especially human freedom will come to that. But so here, I think O'Rourke and his colleagues very nicely say that if we take this whole domain, all these dimensions into the medical model, we can do some very bad things. And either because of this expansionist tendency to say that I can be an expert at everything because I'm a doctor. Sometimes one might come across that in life, right? But there's also a sense of reducing everything to the biomedical. So, just at the risk of sounding too humorous about this, let's say you have data, and I understand that such data exists, that people who are married are less likely to be depressed. So would you say to your single patient, you're struggling with depression, I'd recommend marriage? I mean, the logic is there, but you've gone, shall we say, beyond your scope of practice. Right? That's the point. And so when are we mindful of this? Another example, very serious and well established now, the Jehovah's Witness case in a blood transfusion to an adult. I know you pediatricians by law handle this otherwise for your children, but for adults, we don't collapse the spiritual into the medical and say, we are transfusing you. No, we allow patients to forgo transfusion even as they are dying and then are dead. That's how seriously we take this division of labor, when we do not presume to tell someone what is in their spiritual good. Another example that I would use that recently is if you know in the DSM-5, the change now regarding bereavement, the so-called bereavement exception. It used to be that someone had to have symptoms of depression for 2 months or more before after a death of a loved one, before major depressive disorder could be diagnosed. Now that moved down to 2 weeks. So some would call that as the medicalization of bereavement. And I think my sense is it's driven by issues of function and suffering, the suffering of grieving. But the question is what about grieving is actually fitting and proper? Yes, burdensome, but as we say, part of life. And what if it is not? And so who is medicine and psychiatry to say, we can help you with this. We can help reduce your suffering or improve your function sooner, as opposed to some other domain of knowledge and understanding and wisdom and expertise that says, grieving is part of who we are. It's part of our travail. So those are the kinds of examples I think that we need to think about. So I would want to say that there's an appropriate expansiveness, not expansionistic sort of in that way, but that the idea that we want to be aware of the complete totality of the human life, even as we are modest about our own role in caring for patients as physicians. And so part of that modesty is both knowing what our expertise, where that lies, but it's also being ready to collaborate with those who are so-called expert in that area, right? So a collaborative approach, I think, resonates well with what we're talking about. So now we'll be just capturing more of some of the actual ways that some of the differences in concepts of health can be categorized. And though they get termed in different ways by different people, I think the objective, subjective, for me at least, works pretty well, and I suspect resonates pretty well in a room like this. Now I would say that those who would take a predominantly objective sort of perspective on a concept of health versus subjective versus both. And I will certainly be one to join those who would say that it's the both category. Objective and subjective is what we have to keep in mind. So the objective, I just suspect you're very well familiar with this, so it's basically defining health in terms of disease, which in one sense is sort of a negative way of looking at the question. It's defined in biological and statistical terms. This man named Bourse has been writing about this issue for many years. His whole career seems to be devoted to this in one sense, and he writes extremely well, and so many people have tried to attack him, and he has responded back. So if you ever want to read about this debate, look up his name and his references, and you'll have much good material to read. So health is defined in terms of the absence of disease, and disease and health are objective and value-free. So on the one hand, those of us who took anatomy and then took pathology, we could say, come on, I know what a normal liver looks like histologically, I know what an abnormal one looks like histologically. Where is my value? My value, it just is, it's there. I look at one, I look at the other, and I see the difference, and I understand its pathophysiology. So I understand that there's a certain sense in which we do not hesitate to say something is value-free. But when you look at the whole picture of what health is going to be defined as, we have to then think about what I'll be getting to a little more when it comes to the subjective side. So the purpose of healthcare is to eliminate physiologically abnormal states. And I realize that statistically you would say, well, why do we talk about, say, 2 standard deviations from the norm? We have to draw a line somewhere. And just because it's hard in a given case to know where to draw a line, it doesn't mean that lines can and should be drawn. So the subjective side is to say, basically, it's for patients and society to decide what health and illness are going to be. And they really can talk about things in terms of, for instance, the ability to realize your vital or most essential goals. So getting at this question of this idea of enablement. So you're promoting your patients' health when you are enabling them to live the lives that they want to lead. And so you can imagine my patient who's asking me for an opioid analgesic for his chronic low back pain to say, "Doctor, I can't live my life the way I'm supposed to live unless you help me out." I think that's a very direct way of enabling. Or the woman who says, I need to sleep less so I can do more. Doctor, you're not enabling me, you're not empowering me to do what I'm supposed to do. So you can think in your own specialties of conversations you've had where someone has tried to nudge you to say, wait a minute, you're not doing justice to who I am and how I need and want to live my life. So, another aspect of this is quality of life. I think that this is such a, in my mind, a loaded phrase, and it gets used differently by different people. This is one of those phrases that I would suggest whenever it comes up in a conversation, I'd encourage you to ask someone what they mean by using it. I know sometimes in medicine, and we can have specific meanings like health-related quality of life, and they can actually be defined carefully. But at least when I listen to clinical conversations about, well, that patient's quality of life is so poor, it's just taken for granted that everybody knows what that means, as opposed to actually understanding what it means. There's one person, I think he's a pediatrician, and his name is, I'm not sure whether he pronounces it Siegel or Seigel or Sagel. Sorry?
Sagel.
Sagel, thank you. So it's a Sagel, and he's written very nicely in certain contexts about how it's an all-inclusive concept. And it occurred to me the other day when I was preparing also a presentation related to issues of culture, that if you compare quality of life and culture definitions, there's a lot of overlap. And so it would be interesting, wouldn't it, if somebody ever said to you, well, that patient's quality of life is so poor, if they instead said that patient's cultural situation is so poor. You say, what are you talking about? Culture? I'm talking about medicine and quality of life. Well, again, quality of life, writ large, is a completely sort of all-encompassing concept. So I think we also see this, right? For instance, we have discussions whether it's the extreme of the Terry Scheibel case, the persistent vegetative state, or whether it's children who are born with profound malformations and disabilities, and people would say, well, that would not be a life worth living. It is entirely a loaded statement that I think we can respectfully ask our colleagues or family members or whoever else to say, well, help me understand what you mean by that and why. And let me also respond in kind to say what I'm thinking about that. So, take apart from this here is to say that I think we need a combined concept of health. Because I think any of us who have ever tried to persuade a patient about a matter of health where they are looking at things differently, we know that we have to respect that our patients will also have their own views. So when I tell my patient, well, your cholesterol level is such and such, and so I really think you ought to be on this medicine, they say, Doc, I feel completely fine. And I'm just someone who doesn't appreciate being on drugs unless I think I really have to be. And you have your notions of health and you follow these numbers, and maybe we shouldn't be following these numbers so closely anyhow, doctor. And instead, I have my sense of what health is like for me. It's subjective in the sense of the subject. The patient has their value, their dignity, their freedom. And so we need to genuinely share in that way. And I think the best doctor-patient relationships are constantly doing this, and doing this in ways that both parties understand and appreciate. I just give references here where you can read different people's ways of describing on both sides. And Pellegrino, as you can see in the first one, is one of those who have written very nicely about this. So there's a sense in which we can think about the expertise involved in any of the dimensions of health. And I think that we should not be shy at all to say that our job as people trained in medicine and licensed and board certified is that we have an expertise in matters related to biology and physiology in the healthcare setting. When it comes to psychological, depending upon our specialties, we may have more or less in that regard, but certainly the patient's sense of their own psyche, as it were, is obviously something that is entirely dependent upon. In fact, it's the only access we have, right, to understanding what someone is thinking and feeling and experiencing. And then the social and the spiritual as well. So there's a sense in which we need this modest collaborative approach to do justice to the different dimensions. So if we return to this man, with the infected foot who did not want an amputation, it was clear to me in this situation that this was a man who wanted to be cured. So the goal of care was the same. But that wasn't his only consideration. And you can see this when For instance, the clinicians were so clear that cure for them meant eradication of the infection. The only way to do that was to amputate the extremity. And also to help this man increase his odds of survival, because this man was told, listen, we're concerned that you're going to die in the next 2 weeks from septicemia. And this man heard that, accepted that he heard that, but was not willing to agree with it. It became clear to me that this man was so concerned about his sense of bodily integrity and his sense of self-image and dignity. I think based on certain cultural understandings from his own setting, that's what the medical team was either not understanding or simply not able to resonate with at all. And I think this was an example of these very different concepts of health, the whole package of health. So I think a sense of a sensitivity and awareness of the broader concept from this other man's perspective and these other dimensions would have helped the clinicians. And many of them tried to persuade this patient very hard, I think appropriately for the right reasons. And in the end, I came on late as a clinical ethics consultant in this situation, and I didn't expect this man to even be willing to want to talk to me, because so many people had tried to persuade him, and he probably thought here's one more police officer to try to persuade me to have my leg cut off. And instead, I spoke to him for about an hour, and it was a very profound dialogue in which he was ready to explain himself to me, but it was very hard for me to tease out what was really underneath that. I think in the end I sensed it was this question of dignity and his role as a man in his family and that sense of self-image. It was too hard for him. So what happens when there's a difference of concepts of health, like in that case or any other? If you read literature on this, some would talk about there being an inherentist view. This would be, and someone like Pellegrino would take this view, that there's something intrinsic about human nature, human health, the experience of illness, such that it's not something that society gets to decide what concept of health is there. There's a givenness to what health is and how we should respond to it. I certainly agree with that inherentist view. But I also agree, and all you have to do is read history to see how definitions of health have changed. And it's not just definitions that you might disagree with. You would probably agree with some of those changes and see them as evidence of progress. The question then for ourselves as individuals is, where does that leave us? If we are in a given situation where we don't have the same view as one of our patients or their families might have, and that gets us to conscientious practice, and Dr. Nash will be talking to you about that in a moment. And one of the things I like to say in this setting of conscience and conscientious refusal or conscientious practice is that in a given case, of course, we never stop thinking about our responsibilities to our patients and to society. And there is this so-called social contract between the profession and society. I would not be here if society didn't support the whole medical enterprise that allowed me to become a physician. Right? We owe it to each other to live in the communities and societies in which we practice. At the same time, there is this thing called integrity that we have to live by in our own lives, and so we have also responsibility to ourselves. A note of caution here from Leon Kass, getting at this big picture question of purpose. So he wrote some years ago now, medicine appears to be perplexed regarding its purpose. Without a clear view of its end, medicine is at risk of becoming merely a set of powerful means, and the doctor at risk of becoming merely a technician and engineer of the body, a scalpel for hire, selling his services upon demand. I think these are profound words that will always be relevant, and we need to keep speaking them again. Dr. Kass has written so powerfully about this, and he writes from an Aristotelian, sort of teleological perspective. But it's one that resonates with anyone who believes that life has a givenness and a purpose orientation, and that we are not just providers of means, but we are also concerned about ends. So in terms of wrapping up schematically what I've been trying to say, we can think about the dimensions of decision-making, especially goals, probabilities, and suffering. And then we also, of course, need to have all of that surrounded by an ethical framework, and I would then add also a concept of health, such that we need to have a broad range of concern, so we care about the whole spectrum of what it is to be a human being and to be healthy as a human being. But we have a focused, modest scope of practice and then we very much respect not only our own freedoms and our integrity, but the integrity and freedoms of our patients and their families. And so there's a shared locus of control. So almost wrapping up here now, we can suggest that when we have disagreements, and even though it's a bit of a negative way to put the issue, because at the same time, sometimes when we focus on the most difficult areas of life, we forget the 95% of all the rest of our experience, right? Of all the things that are going so well and all the wonderful encounters you're having as clinicians and caring for your patients and their families. But those moments of disagreement are perhaps sometimes the most painful experiences that we have. And so we regard a disagreement about treatment, taking that step back to make sure we've also talked about goals of care. And then if we're having a disagreement about goals, perhaps we need to take a step back and ask about, wait a minute, what notion of health, what concept of health is driving things? And then if you're having a difference of a concept of health, then you end in this terrain of, in one sense, it's about as existential as it comes in human life. What is a human life for? What is human flourishing about? And this is my last sort of slide here, and that's just to say that I think human flourishing, it surrounds all that we're doing in treatments, goals, and concepts of health, but it gets at questions of dignity, personhood, what choices are really, what freedom is, what preference satisfaction is about, what independence or interdependence or dependence mean, and what suffering is and entails. So I would really end by saying that what we believe really guides what we're willing to do, and also what we say to our patients. And then we have this question that Leon Cass poses so nicely: are we going to be technicians for hire, or are we going to be professionals with a sense of obligation to promote human health? Not just promote human health based on whatever our institution or our government says health to be defined as, but what we actually believe health is. And then we'll have this, of course, this challenge of not only respecting the freedom of our patients to say no, the sense of the negative right to be left alone, which is profoundly important in our society and in the world, I think, but also what does it mean to live with integrity as professionals in all of these interactions with our patients. Thank you very much.